So we was in the question, we was on the क्वेश्चन नंबर 10.5. ओके, एक चीज मेरे को बता दो अभी कि पढ़ने में मजा आ रहा है. आर यू एंजॉइंग द स्टडी? यस और नो, है ना, सो दैट वी कैन इम्प्रूव अवर सेल्फ, है ना. सो आर यू एंजॉइंग द क्लासेस और नॉट? यस और नो, वट एवर इज द प्रॉब्लम्स. एंड यू, इफ यू हैव एनी प्रॉब्लम्स यू कैन राइट मी कि भैया ये समझ नहीं आ रहा. ओके, इफ एनी प्रॉब्लम विल बी देयर जस्ट लेट मी नो, है ना. डीएम मी एनीथिंग कि इफ आई एम गोइंग वेरी, क्योंकि यार दिस इज फॉर यू ओनली ना, तो यू आर द सिलेक्टर, यू विल सिलेक्ट कि कैसे क्या करना है. तो एवरीथिंग हिंदी इज मोर फन. हाँ, तो हिंदी तो बीच बीच में चलता रहेगा यार, क्यों टेंशन ले रहा है. इट विल मोर एंड मोर and sometime perfect. See, Anuj Swami, देखो, it will be for all of you. You can feel that it can be the, it is very much I am studying. बहुत से बच्चों के दिमाग में यही आएगा. When will class finish so we can plan? Not everyone speaks Hindi. Yes, you understand. I understand. I don't speak Hindi, so it's for only for whatever that I wanted to tell in Hindi. I just tell that things. See, many of you thinking about that it will be too much. It will be everything, है ना? But when we will cover and when we will in the last, when we will like do the surgery, when we will do the medicines, है ना? So everything is interchange. We are covering many things here, and we will cover many things more. So in the end, maybe you will get very things. It will be very more things is there. कि भैया ने तो यार बहुत कुछ पढ़ा दिया, बट यार क्या करें, वही तो सिलेबस है ना, तो दैट यू नीड टू स्टडी, है ना. सो दैट यू नीड टू स्टडी, और वो ही रिवाइज करना है. इसीलिए मैं बोल रहा हूँ कि वट एवर यू आर डूइंग, कीप मेक श्योर दैट यू आर डूइंग, कि जो भी वट एवर यू आर डूइंग टूडे, मेक श्योर दैट यू आर रिवाइजिंग ऑन द सेम डे, है ना. डोंट wait for the next days. Like for examples, if you studied today topic, then go for the rheumatology revisions again, because rheumatology we studied at least 1 week. So then you can go for the rheumatology, so that will be make your improve recall important. ठीक है. And don't worry about कि ज्यादा कम, बस पढ़ते जाओ. Just keep studying, don't worry about anything else. So we was on the question number 33. I hope no questions was remaining before. Okay. So we was on the question number 33. See, a 9-year-old child is at hospital with acute glomerulonephritis. Clinical or laboratory examination shows the acute conditions. What nutrient must not be limited during the acute period of glomerular? When the question about note is coming now, so every time thinks what nutrient must be limited during the acute period of glomerulonephritis. So that will be not be the answer. Then select all those 4 options and remaining will be the note. So what is that? In glomerulonephritis study, there is a nephrotic or nephritic syndromes. We studied there is a proteinuria will be there. So there is a decrease in what protein will be there, and along with that salt will also decrease. The salt will also decrease because sodium ion retentions will be decreased, and after that there will be the like free diet. The free diet will also be decreased, and all these will be limited. Like if you see there is a the good fat from our diet, that will also be decreased, because that fat will also seen in the case of in urine. So all these things will be decreased. The liquid, like the more urine will be there, or we can say that more water is seeing. See, when the sodium is the best friend of, or sodium is the girlfriend boyfriend of the water. They both are the girlfriend boyfriend. If sodium is decreasing, so it means water will also decrease from our cells or from our body, and also the fat, proteins, everything, these things will decrease. Only the carbohydrates, they will no effect on the carbohydrates, so it will not be limited in case of glomerulonephritis. I hope this is clear. And so this question is just let us asking about what the like abnormality we will see in case of glomerulonephritis. So we see there is a liquid, fat, protein, salt, all these abnormality will be seen, but the carbohydrate we will see there is a no limitations on during the acute period of glomerulonephritis. In case of the like if it progressives, so in that conditions we can having the problem with the carbohydrate as well. But for acute conditions we don't have any problem with the carbohydrate. There is no limitation of the carbohydrate. Okay. Then the question number 34. So question number 34 is saying a 18-month-old child has taken to hospital on the 4th day of the disease. The disease began suddenly acutely with the temperature 39 degrees Celsius. Weakness is there, cough is there, breathless is there. He is pale, cyanotic, and febrile temperature for over 3 days. There the crepitative fine bubbling rails on auscultation. Percussion sound is shortened in the right infrascapular regions. X-ray picture shows non-homogeneous segment infiltration 8 to 10 mm on the right. The intensification of the lung pattern, your diagnosis will be. See, we studied about the lobar pneumonia, bronchopneumonia, है ना? In the our previous classes, we studied about the lobar pneumonia. In that, I told you if there is any consolidation, if any consolidation of lobe, if any consolidation of the lobe, so that means that will be lobar pneumonia. And so here is what we are saying, that there is a segmental. So if there is segmental infiltration or the segmental consolidation, each lung having the 10 segment. So if I tell you each lung, see each lung having the 10 bronchopulmonary segments, 10 bronchopulmonary segment. So when if any segment having the consolidations, see they give the X-ray picture, but I think they did not give the X-ray picture as well. See the X-ray picture, it's showing the non-homogeneous segment infiltration. So there is a 10 bronchopulmonary segment seen in each lungs. So each lungs, if any consolidation in that segment, that is what? That is segmentary pneumonia. So what was question number? Question number 34. See, in 34 we studied about the bronchopneumonia. We already studied about the bronchopneumonia. See, if bronchopneumonia is there, hello, I want to ask. Bronchopneumonia, if bronchopneumonia will be there, so what will be there? That is also known as the bronchial pneumonia. That is also known as the bronchial pneumonia. Then if you have one or more segment of the lung is concerned, one or more segment of lung is affected, one or more segment of the lung is affected, so that is what we call this condition as the segmental pneumonia. We call this condition as the segmental pneumonia. Okay, then if we see there is a tissue, the tissue between the alveoli, they are consolidated. What is that? We call this condition, if there is a lots of alveoli and the structure between them, those alveoli, that is called as interstitiums. So this condition is known as the interstitial pneumonia. This is known as the interstitial pneumonia. Okay, lobar pneumonia is what? The lobar pneumonia is non-segmental. The lobar pneumonia is what? Non-segmental pneumonia. Lobar pneumonia is non-segmental pneumonia. See, in case of the lobar pneumonia, one lobe is affected or one part of the lobe is affected. So remember that if there any lobe is affected or any particular things is affected, we call this condition, or any part of the lungs is affected. So we can also call this as the focal non-segmental pneumonia. We can also call this condition as the focal non-segmental pneumonia. So what happen in this condition? What we will see? We will see there is a homogeneous. What we will see? There is a homogeneous and fibrinosuppurative. See, I hope you all remember about the inflammation that we studied in the path morpho in Croc 1. We studied about the catheteral inflammations. We studied about the suppurative inflammation, or the, remember, catheteral inflammations, rhinoconjunctivitis and the rhinitis, all the about the inflammation of the lacrimal glands. So catheteral inflammations, we have the fibrinous inflammations, we studied about the suppurative inflammations. I hope you all remember these things. If not, so fibrinous we studied about there is a diphtheritic inflammations. Then suppurative, if it is related to the any bacterial disease or anything. So here what we are seeing, that there is a homogeneous and fibrinosuppurative. There is a fibrinosuppurative inflammation. The very homogeneous and suppurative inflammations and consolidations we will be seeing of one or maybe more lobes, one or more than one lobe. So that means that is condition, that is the structures will be the homogeneous, or there is a fibrinosuppurative consolidation. The images that I send you, the images, so here we are seeing that there is a like all the blacks looks like the white, but the consolidated that will be looks like the little whitish. So that is the homogeneous and the fibrinosuppurative inflammation or the consolidation of one or more than one lobe. We call this condition as the lobar pneumonia. If it is talk about the segmental pneumonia, what will be there? Homogeneous, or there is a fibrinosuppurative consolidation of one segment is there. So that's why that is asked in the question. So here we have the homogeneous segmental infiltration. So that is what segmentary pneumonia. Along with that, we have the feature of the pneumonia. What is the feature of the pneumonia? We have the increase in the temperature. The person can having the cough, and the person will be having the cyanotic because of the oxygen deficiency or because of the hypoxia or the more carbon dioxide in the lungs that can cause the cyanotic conditions. So remember these things. Then we having the other like thing like bronchiolitis, interstitial pneumonia. Interstitial pneumonia, I told you, if there is a problem in the, if there is a like homogeneous masses we seen in the case of interstitiums, like between the alveoli, the tissues that present between the alveoli, that is known as the interstitial pneumonia. The grippy is we call is influenza. Grippy is what? Influenza. Here the grippy meaning is influenza. Okay. So let's continue with our everything about the lungs pathology. The everything about the lungs pathology we will study. Oh, sorry. Okay, I hope this is clear. Yeah, it's clear. See, then we are now let's continue with our like all the lungs pathology and all about the lungs pathology. And in the lungs pathology, let's first discuss about the obstructive and the restrictive lung disease. See, the lungs pathology when we studied, so there are the two things that you already studied little bit. Then first one was the obstructive lung disease. First was the obstructive lung disease, and another was the restrictive lung disease. Restrictive lung disease. See what happened in the obstructive. I told you during the croak one times or in my videos, the obstructive means there is a problem with the expirations when we are expiring the air. So there is a problem with expiration problem. So there is a expiration problem. But in the restrictive lung disease, there will be the inspiration problem. The problem in inspiration. So when we are taking the air in, at that time we have the problem or the inspiration. The problem in the inspiration. So we have the problem in the inspiration problem will be there. Okay, what is the example? For examples, we having the COPD. COPD, that is, what is the full form of the COPD? Chronic obstructive pulmonary disorder. See, in COPD we consider that we having the bronchial asthma. We will be having the bronchial asthma. We having the chronic bronchitis. We will having the chronic bronchitis. We will be having bronchiectasis. That is important, and ask these all four questions like about the bronchial asthma and bronchiectasis. So these all everything was asked in the question in exam, like the last 2 to 3 years the two questions was there. Then we have the emphysema. So this again that becomes the important topic for us. See, let's continue with one by one, and let's first continue with the chronic bronchitis. Or okay, so chronic bronchitis, remember that is again we have the chronic bronchitis, that is the obstructive lung disorder. Chronic bronchitis. See, in chronic bronchitis when we talk, so there will be the inflammation of bronchus, that we everyone know, that is the inflammation of bronchus. There is inflammation of bronchus. So it can be the acute conditions, but majorly we see that is what, that is chronic bronchitis, because when this is, remember this concept, when we are taking the, when any obstruction in the, like the, if I say this is my bronchus, there we have the other secondary bronchus, tertiary bronchus, and then alveoli. See, if any obstructions in there, if any obstructions in the bronchus, so when we are taking the air in, when we are inspiring, so during the inspiration the air will go inside, but when we are expiring, this bronchus will constrict a little. Normal people also, this bronchus will constrict, and when this bronchus will constrict, the air that is coming inside or there that wanted to go outside, that will not able to go because of this the little constriction of the bronchus during the expiration. So this air will be trapped here. So that which air is there here? That is carbon dioxide. So carbon dioxide will be trapped here. This is the like phenomena for all the obstructive disorder. So remember this concept whenever we are having any obstructions in during the bronchus, in the bronchioles. So when we are inspiring, the air will go through this path, but when we are trying to expire the things, when trying to expire the air, this bronchus will constrict a little bit, and the whole it will become the complete obstruction. So the air that is present inside will not able to come out, and that's why there will be the accumulation of carbon dioxide, and then we call this condition as the obstructive lung disorder. I hope this is clear. We call this condition as the obstructive lung disorder. So in chronic bronchitis patients, in case of the chronic bronchitis, always remember we will be having the persistent productive cough. What will be having? Persistent productive cough will be there. There will be the persistent productive cough will be there. And we need to, if it is chronic, then we need to ask about the time also. So persistent productive cough for at least 3 consecutive months, for at least 3 consecutive months, and we will check for the at least minimum till the 2 years, and there is a long history of the 2 years. So it should be the minimums within the 2 years, it should be the minimum, there is a 3 consecutive months should be there, 3 महीने होने चाहिए continue, and for that in the minimums 2 years, in minimum 2 years. So that you need to understand. See, other things we can having in this patients. Also remember, we need to rule out all the diseases. Like we need to rule out the differential diagnosis. This is the differential diagnosis. Okay, I hope everyone knows what is the differential diagnosis. So differential diagnosis means a similar type of the disease and having the similar characteristics which features, but they are the differentiating in the one or two features. The both things looks like the similar, but they are differentiating in one or two features. That gives the possibility of the same disease, like, so that we have the differential diagnosis for that, and the differential diagnosis for this condition is what? That is tuberculosis. That is tuberculosis. An important thing, remember, whenever we are diagnosing the chronic bronchitis, one patient asked in our OPD or in our OPD and in our hospitals, and so that we will rule out all the possibility. If the person say I having the productive cough, if I having the productive cough, so we will firstly we will rule out all the possibility that is possible due to productive cough. After that we will feel that okay, this patient having the 3 consecutive months and the patient having the history of what 2 years, then we will consider that okay, it is chronic bronchitis. So important, remember, this is the important point here. You need to, all other causes should be ruled out. All other causes should be ruled out. Should be ruled out. So what happened in the chronic bronchitis? What is the like etiology for that? See, the 90% this obstructive lung disorder is seen in case of the smokers patients. So the 90% this is seen in case of the smokers patients. So whenever we are taking any foreign materials like any spicy food or any like the smoking agents, any foreign body that is going inside our, or any like opposite or any things that injure our mucosa or injure our any other body parts. So that when you will irritate, if someone will irritate you, what you will do? You will be having patients for 1 day, for 2 days, for 3 days. Then after that you will be having the super hypertension. BP will be increased, and after that what you will do? You want to kill that person. So that's what our body do. If any person is taking smoking and he is chronic smoker, so in that condition the mucosa will irritate. The mucosa will irritate. So he will release his or her protective factors. So what it will do? This mucosa, then what it will do? It will increase the mucus quantity. It will increase the mucus secretions. So when the mucus secretion will be increased, there will be the increased risk of infections. There will be the increased risk of infection. So infection risk will be increased, and there will be the most commonly, if I will say, the most commonly will be Haemophilus influenza. Haemophilus influenza will be there. Then after that, if you are saying there is an increase in mucosa, along with that there is an increase in the RAID index. There is an increase in the RAID index. So see, mucus, always remember, it is secreted by the submucous layer. Submucous layer. In submucous layer, we will having the mucus gland. We are having the mucus gland, and when will be the hypertrophy, the mucus gland size will increase, there will be the increase in the mucus productions, and that will lead to the further increase of infection. Along with that, there will be the also there will be this mucus secretions that will be the cause of productive cough. That will be the cause of productive cough. So there is an increase in the RAID index in case of chronic bronchitis. There will be the increase of what? RAID index in case of chronic bronchitis. I will discuss. And also remember that it is associated with, AW means that is associated with, it is associated with cor pulmonale. It is associated with the cor pulmonale. So what will be happen in the cor pulmonale? There will be the pulmonary hypertension. There will be the pulmonary hypertensions with right heart failure. There will be the pulmonary hypertension with right heart failure. So that you need to understand that it is associated with the cor pulmonale. What is RAID index? See, RAID, I told you that is a mucus gland atrophy. So remember the RAID index is what it is. It defined as the ratio of the thickness of, if there is a thickness of submucous gland, the thickness of submucous gland divided by overall thickness, divided by the overall thickness of alveolar walls, wall of alveoli or the bronchus. Okay, so the normal RAID index you need to remember that is equals to the 0.5, but in chronic bronchitis you need to remember that in chronic bronchitis, this is chronic bronchitis, this will be increased. That you need to understand. As I just told you, there is a submucous layer gland, the mucus gland hypertrophy will be there. The mucus gland hypertrophy will be there, so you can easily understand from that things there is a thickness of the submucosal gland, and due to which the RAID index will be increasing. So if in the question they giving the value of the RAID index, you can easily identify that it might be talking about the chronic bronchitis. So remember these very important key points or the key words of the chronic bronchitis. And see, this is very simple things we discuss in very simple manner. See, chronic bronchitis, we know the inflammation of bronchus, we know the productive cough is there, and minimum it should be 3 consecutive months for at least 2-year history should be there. Then we studied the all other causes should be ruled out. Then 90% it is associated with the smoking. They will mucus secretion, RAID index or the cor pulmonale. That's it. That is what chronic bronchitis. Then other important question that asked again in the last 2 to 3 years paper, that is bronchial asthma. That is bronchial asthma. See, bronchial asthma. Remember, bronchial asthma, we all know that it is the type 1 hypersensitivity. There is again the bronchoconstrictions will be there, obstruction of the bronchus will be there. Everyone knows these conditions. But in case of now, we will study little bit extra that when we are doing the sputum, we will take the patient's sputum, and when we take the sputum, we will take the sputum microscopy. So what will be seen in sputum microscopy? There will be the Krusemann spiral. There will be the Krusemann spiral. What is this Krusemann spiral? This is the walled mucus plug. Walled mucus plugs. The images they will not ask you, so we are not discussing the images. But you need to just remember that is the Krusemann spiral. If anyone wants to images, you can just Google the Krusemann spiral, Charcot-Leydig cells, and all these things. But that is not needed. So just remember we have the Krusemann spiral. Along with that, we will be having the Charcot-Leydig cells. We will be having the Charcot Leydig cell. And after that Kurzman spiral, we will be having the Crayola bodies. So these three bodies or the three things you need to remember based on the sputum. Okay, I hope this is clear. The Charcot Leydig cells and we have the Crayola bodies. So always remember the Charcot Leydig cells, they are made up of the galactin 10. Charcot Leydig, sometimes we call it crystals, and also remember these are what? These are the needle shaped crystals. These are the needle shaped crystals. And also remember that it is made up of galactin 10s. It is made up of galactin 10s, and it is what? It is the needle shaped crystals. And one finding you can find, like you can see in the questions, eosinophilic membrane something. If they will not give you the Charcot Leydig cell, they will give you characteristics of the Charcot Leydig cells. So you will see there is eosinophilic membranes, galactin 10, protein galactin 10s, and the needle shaped crystals. So you need to understand he is talking about the Charcot Leydig cells. Then we have the Crayola bodies. You need to remember that. Then we have the like Crayola bodies. Just remember the Crayola bodies. And again, if you want to talk, that is the epithelial cell clusters that you can remember it. But most probably they will give you the name of these findings. Most probably they will give you the name of the findings, but they have the habits of giving the characteristics. So they can give you, there is a whole mucus plug, there is a needle shaped that is made up of the galactins. Then we have having the epithelial cell clusters. So this you need to remember. Okay, that is very, very important. I hope this is clear. Now let's continue with the, I think, what is the RAID index? If you find, so you can easily differentiate based on the RAID index. See the RAID index in bronchial asthma, that will be the normal. There is a no hypertrophy of the submucosal gland, so that will be the normals. Okay. Also you can remember in the bronchial asthma, that can be the ask. In lungs we will see there is a airway remodeling will be seen. In lungs what we will see? Airway remodeling. In lungs we will see the airway remodelings, and also remember there will be the thick mucosa that will become the thick. So the mucosa will be thickened. And due to this mucosa will be thickened, so there will be the increase in the goblet cells. And also remember there is a basement membrane is also thickened. So remember these things. That is, I think, more than enough. So in the lungs we have the airway remodeling, mucosa thickened, increase in the goblet cell, basement membrane is thickened, and the RAID index for this condition is the normal. See, there is also we will see there is a submucosal gland increase. That's why we have the mucosal thickened will be there. But along with that we will having the wall also increasing. That's why the RAID index will become normal. I hope this is clear. Okay, because of that we will having the RAID index will be normals. So remember these three bodies are very super important. Kurzman spiral, Charcot Leydig cell, Crayola bodies asked in every exam, and this whole topic actually asked in all the exams, so you need to remember this thing. After that we having the emphysema. See, what is emphysema? This one we also like study in our Croc one time. See, the emphysema, remember when we are talking about the emphysema, we are saying that is the leather bag appearance, है ना? SM gland, submucous gland that will be increased. When I speak, I write, है ना? So focus on my wording also. So that is submucous gland. So if emphysema, what happens? There is a permanent damage to the airway. If there is a permanent damage to the airways, again it is also associated with the smoking. The permanent damage to the airways. See, in emphysema we say that acinus is affected. What is acinus? Acinus is affected. And if acinus we talk, what is acinus? See, acinus is what? It is the combination of the acinus. We know it is combination of respiratory bronchioles. It is the combination of respiratory bronchiole. It is a combination of alveolar duct. It is a combination of alveolar duct, and it is a combination of alveolar sac. It is a combination of alveolar sac. Okay, all these things combine to form the acinus. So in emphysema, respiratory bronchiole is affected, alveolar duct is affected, alveolar sac is affected. I hope every one of you know that we have the bronchus, and after the bronchus we have the primary bronchus, then secondary bronchus, then we will be having the tertiary bronchus, then we will be having the bronchioles, and after the bronchioles we have the primary bronchioles, we have the secondary bronchioles, and we having the tertiary bronchioles. So after the tertiary bronchioles we will be having the some little bit alveolar duct, and after the alveolar duct we will having the alveoli. So we having the primary, I'm repeating, we have the primary bronchus, we have the secondary bronchus, we have the tertiary bronchus. After the tertiary bronchioles, we have the primary bronchioles, we have the secondary bronchiole, we have the tertiary bronchioles. Our tertiary bronchioles is also known as the respiratory bronchioles, and we will be having the, after that we have the alveolar duct, and after that we having the alveoli. So all these will be affected in case of emphysema. Okay, I hope this is clear, right? So what is that? Acinus, you can also remember, this is the functional unit of the lungs. This is the functional unit of lungs. This is the functional unit of lungs. The functional unit of the lungs is what? That is acinus. So there is an entire respiratory tract. When we talk about the entire respiratory tract, remember the entire respiratory tract, it is what? It is lined by pseudostratified. This is little bit histology point. So pseudostratified columnar epithelium. It is lined by pseudostratified columnar epitheliums. Then we have the except, there is some exception, and exception we have, that is like vocal cords. In the vocal cords, remember, we will be having the stratified squamous epitheliums. Stratified squamous epithelium. Okay, this one you can understand. The entire respiratory tract, there is a pseudo-stratified columnar epitheliums. When your mucus will be affected, so these pseudo-stratified columnar epithelium, they can change to another epithelium. That condition is known as the metaplasia. And also remember, in case of emphysema, if we see on the microscopy, on microscopy, what we see on microscopy, ME is what? Microscopy. Microscopy is what? ME. So microscopy, we see there is a floating septa. What we see? Floating septa. What other clinical features we see in case of emphysema? Other clinical features or the clinical presentations we see that there will be the pink puffer. These babies are also known as the pink puffer baby. Pink puffer baby. Because what they will do, they will take in the oxygen, but carbon dioxide will not able to go out. They will stuck in the respiratory bronchioles, alveolar duct, alveoli sac. That's why they call this baby is also known as the pink baby, pink puffer baby. If we see the radiologically, what we will see there is a flattening of the diaphragms. In case of emphysema, there will be the flattening of the diaphragms. Radiologically, we see there is a flattening of diaphragm. There is a flattening of diaphragms. Okay, so this what we is important for the CROC 2 point of view, and in CROC 1 time we studied about there is alpha 1 antitrypsin enzymes, and that enzymes will come and will then that secreted by the macrophage, and when this macrophage, our body, it act as like the foreign body. So any foreign body or the coal particles will comes, the macrophage will comes, and this macrophage will vomit, and when this macrophage will be vomit, alpha 1 antitrypsins enzyme is there, and that alpha 1 antitrypsin enzyme, they will help in the providing the elasticity of the alveoli. And once this alpha 1 antitrypsin deficiency will be there, so that will lead to the the alveoli of the or the lungs will become non-elastics, and that will lead to the like the ballooning of the alveoli, that will lead to the ballooning of the alveoli. That's what we discuss in our croak one time. I hope you remember that things. If you don't remember, just recall these things what I told you now. I think, or this one is important for you can remember the exceptions. You have the vocal cords, that is stratified squamous. Other we have the pseudo stratified columnar epitheliums. Okay, the next or the last one obstructive lung disorder we have, that is bronchiectasis. We have bronchiectasis. See, in case of bronchiectasis, what we see bronchiectasis is again the important point, and the in one paper like I think 2023 paper. So this bronchiectasis questions, bronchial asthma question, emphysema question, chronic bronchitis questions. There was a 4 questions from all these topics. One question about the bronchial asthma, one question about the bronchiectasis, Carter-Jenner syndromes, and there was a like integrated questions, bronchiectasis, along with that there is a Carter-Jenner syndromes. So remember, if there is a abnormal permanent dilatation of bronchi or the alveoli, we call this condition as the bronchiectasis. What is that? Abnormal permanent dilatation. If abnormal permanent dilatation of bronchi and bronchioles, so that condition is known as bronchiectasis. See, we have the 2 causes of the bronchiectasis. When we have the congenitals, it can be congenital cause, or another cause we have that is genetic. Another cause we have that is the acquired. Okay, the congenital we can say that is due to genetic, and there are the 2 causes of congenitals. What are these? These are like the genetic we have the Carter-Jenner syndromes. What we having? The Carter-Jenner syndromes. Carter-Jenner syndromes. Other conditions we have, that is cystic fibrosis. Cystic fibrosis. Okay. Then acquired cause we have like obstruction. Acquired we having the obstruction, or maybe any inflammations is there. Maybe any infection is there, we can say. See, obstructions, it can be due to foreign body. FB, what is what? That is foreign body. Foreign body. And other obstructions we having, that is tumor. Okay. So we have the congenital like genetics, Carter-Jenner syndrome or the cystic fibrosis. Acquired we having the obstruction or the infections, we have the foreign body, and we will be having the tumor. This Carter-Jenner syndrome, that is important again for our exam. So remember the Carter-Jenner syndrome, this is also known as immotile cilia syndromes. So from name you can understand that there is a immotile cilia is there, and along with that there is another name of this condition, that is known as the primary ciliary dyskinesia. Another name of this condition is the primary ciliary dyskinesia. Okay. What is the problem in the Carter-Jenner syndrome? There will be the defect in dynein protein, the defect in dynein arm of cilia, or you can see, remember, it is the dynein protein problem. There is a defect in the dynein protein, or the defect in the, you just remember the dynein, you will understand there is a problem in the dynein. Just remember this thing. Then there is a important triad here. See, in case of Carter-Jenner syndromes, one we already studied that we are seeing that it is due to bronchiectasis. It is due to bronchiectasis. Along with that, we see there is a chronic sinusitis. What we will see? We see there is a chronic sinusitis. Yeah, we will see there is a chronic sinusitis, or normally sinusitis can be also seen. Then we will having the situs inversus. Anyone know what is situs inversus? Write me in the chat box, what is situs inversus? Situs inversus. No one knows. See, there is a bronchoectasis, chronic sinusitis, and the situs inversus. Normally, we having the, see, when where on which side we have the heart, left side or right side? Normally, we have heart on the right side, right? Normally, we have a heart on the right side or left side. Which side we having heart? Yes, Anuj Swami is right. That is position is flipping. Okay. So the situs inversus, remember, we will be having the heart, that is normal heart, we having the left side. So we can code it as the levocardia. But in case of the situs inversus, you will see there is a dextrocardia. And I also saw one lady also during my clinical, or when I was in hospital, I saw the one lady having the situs inversus problem. I see that there is a right sided, normally we having the right sided liver. This lady having the right side, left sided liver, she will having the right sided spleen, she will having the all the opposite, or she having all the opposite organs. So that is what the like for examples we can remember that there is a dextrocardia, the right sided heart will be seen in case of Carter-Jenner syndrome and the patient having the bronchoectasis. Okay, along with that, in the Carter-Jenner syndromes we will be having the male and female infertility will be seen. These patients can having the male or the female infertility will be seen. Along with that, we will see there is a mainly the lower lobe, mainly the in case of the low bronchoectasis, and due to which the lower lobe, or mainly that will be the bilateral. On BL means bilateral. That means on the both side will be affected. So the lower lobes are usually affected. The lower lobe are usually affected. I hope this is clear and done. See, there is a Carter-Jenner syndrome, that is immotile cilia syndrome, primary ciliary dyskinesia, the defect in the dynein protein of the cilia. The triad we studied, that is the bronchoectasis, chronic bronchitis, chronic sinusitis, situs inversus, and the male and female infertility, the lower lobe bilateral are usually affected. Is Carter-Jenner syndrome genetic? Yes, what I write. See, the congenital, this is the congenital problem or the genetical problems. Okay, the congenital or the genetical problems. That is Carter-Jenner syndromes. Another we have in the cystic fibrosis. Okay, just give me 2 minutes, I will be back. Okay, I'm back. So we have studied that we having the Carter-Jenner syndrome, and also remember if we talk about the Carter-Jenner syndrome, we talk about the complications. So remember the complications as well for these conditions. See, in case of Carter-Jenner syndromes, we will be having the complications. So the complications we will be having like lung abscess. There can be the abscess formations. There can be the brain abscess. There will be the empyema, brain abscess, empyema will be there. And along with that, we can see there is a amyloidosis. You don't need to remember for now. Just remember the just complications. Remember the complications: the lung abscess, brain abscess, empyema, like pus in the cavity, and the amyloidosis. We having the AA. You can remember the AA amyloidosis. Amyloid will be deposited. The AA amyloid will be deposited. Okay, so this is the complication that you need to remember. Okay, then we need to understand the cystic fibrosis as well, because cystic fibrosis again the important point. See, in case of the cystic fibrosis, so whenever the cystic fibrosis the questions will comes, the two things should be come in your mind, that is also known as mucoviscidosis. What is that? Mucoviscidosis. Mucoviscidosis. So this cystic fibrosis, this is also known as the mucoviscidosis, and this condition is what? This condition is the autosomal recessive condition. AR means this condition is known as the autosomal recessive conditions. This is autosomal recessive conditions. There will be the CFTR gene mutation. They are the CFTR gene mutations will be there. They are CFTR gene mutations. See, what is the CFTR gene mutations will do? They will inactivate the chloride. This question again come. See, yesterday what we studied, everything comes in exam. Whether it was question about the lobar pneumonia, whether it was the chronic bronchitis, the bronchial asthma, emphysema, bronchoectasis, and after that cystic fibrosis, all these questions came in one paper. Okay, so that important it is. CFTR gene mutations will be there. What they will do? They will inactivate the chloride channel. They will inactivate the chloride channel. So when the chloride channel will be inactive, so what they will do? They will bake the mucus thick. They will make the mucus thick. So their mucus thickness will be there, and that will I told you that if there is an increase in the mucus, if there is a, here I told you that if there is a increase in mucus, so there is increase in mucus, there will be the increased risk of infection. Here I told you, if there is increase in mucus, there is increased risk of infection. So here you can remember कि here also we will having the chloride ion inactivation, due to which mucus will become very thick, and there will be the increased risk of infection. Okay, I hope this is clear. Okay, so remember this one, we have the CFTR gene mutations, and we are having the inactive chloride channels. After that, remember one more thing here, that in case of, if we talk about the clinical features, CF is what? Clinical features. So here what we will see this patient having the recurrent pneumonia. These patients will be having the recurrent pneumonia. And what is the most common cause of recurrent pneumonia? What is the most common cause of recurrent pneumonia? That is Staph aureus. That is the Staph aureus. That is the most common cause of recurrent pneumonia. Along with that, these persons we are talking about we started with the bronchoectasis. So of course these patients will be having the bronchoectasis. Along with that, they have the bilateral nasal polyps. So this triad you need to remember. This is the respiratory triad that we seen in these conditions. This is the triads: bronchoectasis, recurrent pneumonia, bilateral nasal polyp, that will be seen in these conditions like cystic fibrosis. I hope this is clear and done. What other conditions that we can see in these conditions that can also be given in the questions? See, there will be the patients, this patient will be having the most common characteristics feature. This is the respiratory problem we've seen in these patients. Other than, we can see there is a GIT problems. In the GIT we can see this patient having the meconium ileus. I hope everyone know what is the meconium. Meconium is the first stool of the baby, is what? Meconium. The first stool of the baby will be the meconium. Along with that, we will this patient having the malabsorptions. malabsorption. This patient, I think this is not visible. These patients will be having the malabsorption. So malabsorption will be there, and if the malabsorption will be there, these patients will lead to the chronic diarrhea. These patients will lead to the chronic diarrhea. These patients will lead to the chronic diarrhea. Along with that, in these patients, what we will see there is a pancreatic insufficiency. What we will see, the pancreatic insufficiency. And if there is a pancreatic insufficiency will be there, their pancreatic enzyme problem will be there, and then it will lead to the steatorrhea. What is the steatorrhea? Steatorrhea is the fat in stool. Steatorrhea is the fat in stool. That is what steatorrhea. So there is a pancreatic insufficiency, and along with that, we know the pancreatic enzyme, they help in the absorption of the lipids or the fat, due to which there will be the problem in the vitamins, or the deficiency of which one? Vitamin A, D, E, K. One question also solved from here, which is fat soluble vitamin. So we have the fat soluble vitamin. What are the example of the fat soluble vitamins? That we having the vitamin ADEC. So ADEC. So these are the fat soluble vitamin. These are the fat soluble vitamin. I hope this is clear and done. Other conditions are also possible, but I think this is more than enough. See, if these patients can having the male infertility also, because I just told you that there is a problem in the Carter-Jenner or in the cystic fibrosis as well. We having the problem with the cilia, and due to which there will be the male infertility also possible. Male infertility also possible, and along with that, we will see this patient will having the cholestasis. Cholestasis means accumulation of the bile. Coli means bile, stasis means इकट्ठा हो जाना, है ना? That is accumulation. So accumulation of the bile can be the possibles. So remember other very important features that that will able to differentiate in your croak exams. So when we are seeing the sweat, so if there is sweat is there, so that sweating will be excessive salty will be there. Excessive salty. So it means this patient having the high level of sodium and chloride. High level of the sodium and chloride. So that you need to understand. So if this patient is having the sweating, that is excessive salty sweating, that means this patient having the high level of the sodium and the chloride. Along with that, this patient having the recurrent pneumonia, bronchoectasis. So these all are the keywords. What are these? Like if there is a salty sweating, bronchoectasis, recurrent pneumonia. So all these are the important keywords for your exam for this question. Cystic fibrosis, definitely in the question you can get the salty sweating. If not salty sweating, bronchoectasis can be there. If bronchoectasis is there along with there is a salty sweating, that means he is talking about the cystic fibrosis. Okay. There is other different diagnostic criteria, but for your for croak 2 exams, I think that will be the more than sufficient. If the bronchoectasis is there, salt sweating is there, any feature of the recurrent pneumonia is there, so that means that is the more than enough. And then other than that, you don't need to remember anything. So this is again, I'm highlighting the point that is again the more important here. See, this keyword you will able to find. We will see the questions and you will see, okay, this is the answer. We will see that there is a autosomal recessive condition. We see there is a CFTR gene mutations. Along with that, we will be having the recurrent pneumonia will be there, bronchoectasis will be there, and bilateral nasal polyps you can get in the questions, but most probably you will not get. So you will get the bronchoectasis, recurrent pneumonia, and along after that, one more keywords you can see in the questions. Malabsorption will be there in all the questions of the croak 2, and along with that you can see the steatorrhea in the in your questions. Male infertility you can find in the question. Along with that, all the questions most probably you will get the excessive salty things, and whenever the excessive salty things in your questions, please think about the cystic fibrosis. If the first check the options, if there is something about that, and all the rule out all the options, mark the answer cystic fibrosis. Okay, I hope this is clear and done. Okay, so after that let's continue with our After that, what we need to study? We need to study about the other lungs pathology. See, this is the completion of the obstructive lung disease. Okay, so obstructive lung disease, let me revise it here only. So obstructive lung disease, we studied about the chronic bronchitis, we studied about the emphysema, we studied about the bronchial asthma, we studied about the bronchoectasis. Bronchoectasis, we studied about the Carter-Jenner syndrome, we studied about the cystic fibrosis. So both these are very, very important, and these all are the obstructive lung disease, and these all are the example of the COPD, chronic obstructive pulmonary disorder. In asthma, remember, we have the Corolla bodies, we have the Krusman spiral, and we have the Charcot-Leydig cells that again become very important. Emphysema, we studied that there is a pink fever as soon as it is affected. In the chronic bronchitis is associated with the smoking, so there is a RAID index will be increasing in the case of chronic bronchitis. Okay, then let's continue with the restrictive lung disease. The restrictive lung disease, again, in the same question that around like in 2023. So from the restrictive lung disease, I think there was a 3 questions about the silicosis, and 1 question about the siderosis, and so there are the 3 questions from the restrictive lung disease. So let's continue with the restrictive lung disease, that is again the important one. So in the restrictive lung disease, remember the example of the restrictive lung disease. See, one we having the example of the restrictive lung disease is the sarcoidosis, and other examples we having the pneumoconiosis. This is pneumoconiosis. Sarcoidosis, let's study 1 or 2 lines. I think that is not important for your exams. So sarcoidosis, remember, that is the most common organ affected is the lungs. The most common organ affected, that is lung. If there is a most common, if they will ask you like what are the symptoms, you can just remember the symptoms. If eye is affected, there will be the uveitis. If there is involvement of the glands, so that will be mucolysis disease, that we studied in case of which granuloma? Micule or mucul. In the mucul having the rhinoscleroma. I don't have the rhinoscleroma, but for remember, just remember mucolysis disease or the mucolysis granuloma, that we studied in case of rhinoscleroma. If the gland is involved in sarcoidosis, we call this condition as the mucolysis disease. And also in case of the skin lesions, what we will see, the skin lesions also we see the erythema nodosum. Which skin lesion we see, that is the erythema nodosum. Again I am saying that is this topic is not important, but you can remember what I am just telling you, just few points about the sarcoidosis. With this sarcoidosis, this one is important point. Since sarcoidosis, you will getting the both granuloma, known cageating granuloma. Along with that, what you can see, is there will be the cageating granuloma, and non-cageating granuloma, that is most common, that is seen in case of sarcoidosis. Along with that sarcoidosis, you can remember there will be the asteroid bodies. So that is the keyword or the feature that will able to mark the correct answer. And also there is one more bodies that we call it the Showman bodies. So this you can remember. I think this is more than enough. Showman bodies. These are the calcium bodies. Okay, Showman bodies or the asteroid body. These are some keyword findings that will able to make the diagnosis. Okay, so this you need to remember. The calcium level will be increased in this condition, and ACE will be increased. CD4 CD8 count ratio will be increased in case of sarcoidosis. And also remember, in the liver they cause hepatitis, but that hepatitis is non-infectious. So all these things about the sarcoidosis, just you need to remember which organ is most affected, that is the lungs. In the eye they can cause uveitis. If it is affecting the gland, they cause mucolysis cells. And also you will see some keyword features like asteroid bodies, Showman bodies, and if they will ask you for the diagnosis, you can easily mark that okay, this is sarcoidosis. Now the next restrictive lung disease that is very important, that is pneumoconiosis. that is pneumoconiosis. After that we will take a little break and then we will continue. What he is sending? Anuj, what you wanted to send? Little break maybe. Okay. Complication of bronchoectasis once more. The complication of bronchoectasis, we will be having the lung abscess, we will be having the brain abscess, we will be having empyema and the amyloidosis. In amyloidosis, we have the AA amyloidosis. Mani Dhiraj. We have the lung abscess, brain abscess, empyema, amyloidosis, AA amyloids. Okay, let's take a break and then we will continue with the restrictive lung disease. I think 10-minute break will be more than enough. So 10 minutes at we will start at the 11. Who is this? Okay, so let's take a break and then we will continue.
सेठ जी ने बहुत सारे मंदिर बनवाए लेकिन कभी खुद एक कांच है ऐसे कंकड़ मारो टूट जाएगा और एक कांच है गोली मारो तो नहीं टूट
Who is Bahira Stat? Can you please write your name, full name? Uh, can you please write your full name, Bahira? Bahira Stat. Who is that? Okay, CEO. Okay, got it. Yeah, you told me. Okay. Okay, so shall we start? We are 2 minutes away. Okay, write me. Let me know some questions. So those who are active and those who are here, just text me or write me in chat box by just seeing your notebook or whatever. So tell me, what is the another name of cystic fibrosis? Another name of cystic fibrosis. Oh, the screen is there. Sorry. Okay, what is the triad that we seen in case of Carter-Jenner syndromes? What is the triad that we seen in case of Carter-Jenner syndromes? Just try to recall without notebook. The triad that we seen in case of Carter-Jenner syndromes. Bronchoectasis, cytosine versus, and the what was that? CR cyanocytosis. Chronic sinusitis. It was sinusitis. Okay, sinusitis. Or okay, tell me, like, if you're getting the sweating, like salty sweatings, nasal polyp. Okay, where we studied. What is that Fallot? Where we wrote the Fallot? We didn't write the anything Fallot. Okay, the emphysema is covered, so everything is covered, I think. Okay, so let's continue and then you start. Wheezing can only be in the asthma, or we can find it in any other disease. Then tell us about the auscultation finding in these diseases. Anurag Sani, wheezing we can find in any conditions. Wheezings, I will just, it's like the rails or the wheezing, something we can find it like asthma or any disease having some obstructions, having nasal blockage. So in any conditions we can find. So this is not a specific finding for the asthma. Auscultation finding in these disease. Which disease? Auscultation finding, yesterday I told you that you need to understand. See, whenever we are seeing that if any lobe is affected, है ना, band box सब आएगा band box, resonance, tympanic, that is just a like the characteristics finding of the radiologicals, like the sign we seen like tympanic sounds or the band box resonance. So everything we will cover maybe in the next class, or because today we need to cover about the lungs pathology. So everything will be covered there, so don't worry about it all, है ना. Band box resonance, tympanic, hyper resonance, hypo resonance, everything I will make it small tables and we will cover that everything. There are lot of thing I know, क्योंकि मैंने भी जब मैं भी पढ़ता था तो मुझे भी वो चीज प्रॉब्लम आती थी ना, नए नए सब्जेक्ट्स, क्योंकि देखो that is what is naturals that we already studied, but जैसे कि for the Croc 2 point of view there is a many different terminology that we also need to study, so we will study according to that. So like band box और बहुत सारी चीजें आएंगी अभी तो. Okay, so let's continue our restrictive lung disease. So see, in the case of restrictive lung disease we studied about the sarcoidosis. Now we continue with the pneumoconiosis. We studied about the I hope everyone is here. Just please raise your hand, everyone. Okay, everyone is here. So we have studied pneumoconiosis. Okay. बस हो गया. I understand. ठीक है. So we have the pneumoconiosis. So the pneumoconiosis, remember we will be having, this is known as the occupational disease. This is what we have, the occupational disease. So any occupational conditions, any occupational condition. So any occupational disease we consider it is under the pneumoconiosis. So the most important we having the silicosis, and that is the most common pneumoconiosis. See, if you are getting the silicosis, remember this question came in the last two exams. So this is the most common pneumoconiosis. The most common pneumoconiosis. Then what the silicosis, when it will be there, it will be seen in case of glass industry. Where it will be seen? It is seen in case of the glass industry. Then if we talk about the lungs, in the lungs what we will see? We see there is a nodular fibrosis. What we see? There is a nodular fibrosis will be seen. Nodular fibrosis will be seen. And on the when we say about the lymph nodes, so there will be see egg cell calcification. There will be the egg cell calcification. So remember the silicosis, where it will be seen? It is due to glass industry, or exposure to the glass industry we will be seen. Then in the lymph node, where it will seen? Egg cell calcifications will be seen. In case of if you have the patient having the silicosis, so in that patient there is an increased risk of, TB and cancer. There is increased risk of TB and cancer will be there. The increased risk of the TB and cancer will be there. The other conditions we will be having, that is coal worker pneumoconiosis. The coal worker pneumoconiosis, this question again came in the exams. The coal worker pneumoconiosis. Coal worker pneumoconiosis, first like we have the anthracosis. We having the anthracosis. So that is coal worker pneumoconiosis. Anthracosis, remember, if you are getting the black lungs and it is due to coal industry, black lungs and anthracosis, it's mainly due to, seen in case people having the working in the coal industry. The people working in the coal industry, in that things what we will see, the black lungs or the anthracosis will be there. Okay. Then the next one we having the, or you can remember the third one, that is asbestosis. The third one is what? That is asbestosis. See, all the pneumoconiosis, all the pneumoconiosis we will study, silicosis or the anthracosis, we will study about the bicinosis, bagosis, berylliosis, batitosis, stenosis, siderosis. All these pneumoconiosis, what they involves the upper lobe, except there is a one pneumoconiosis, asbestosis, that involves the lower lobes. It involves the lower lobe of lung. Okay, so you can write it here as it is, all pneumoconiosis. Write it, all pneumoconiosis involves upper lobe except asbestosis. So asbestosis, there will be the lower lobe is involved. Okay. So they have the two forms, like it have the amphibolic forms or the serpentine forms. So how it will be like transmitted, or how it will be like occupied by any patient? So if you are inhaling the asbestos, inhaling the asbestos, so where we will get the asbestos? So there will be the history of shipyard, industry. If any shipyard industry is there, or we can say there is a cement industry, or there is a cement industry is there, so that in that conditions what we will see there will be the asbestosis. So inhaling asbestos, the history of the shipyard industry or the cement industry, so in that conditions the patients will be having the asbestosis. The exposure of the cement, exposure that people working in the shipyard industry, they are affected with the asbestosis. What the clinical features, they are also important in this condition. See, this patient firstly will be having the pleural plaque will be formation. The pleural plaque will be there. After the pleural plaque, these patients will be having the pleural nodule. The pleural nodule will be there in these patients. And this pleural nodule, we call this as the asbestos. or ferruginous body. What we call this? Asbestos or the ferruginous bodies. So this is very important. These are very important bodies, asbestos or the ferruginous body. And when if these plural nodules the further complicated, they will further complicated, and what they will do, they will lead to the cancer. They will lead to the cancer. Now the very important question here, which is the most common, the most common element associated with the adenocarcinoma, or the most common asbestosis is what? That is cause the which cancer? Adenocarcinoma. Which is the most common cancer associated with the asbestosis? That is the adenocarcinoma of the lungs. Now can you tell me which is the most specific cancer associated with the asbestosis? So that is what? That is mesothelioma. So mesothelioma. We know that there is asbestosis. So you can remember S for we having the specific. S for what you need to remember? The specific. Or I can write with this so we have the S here, again we having the S here, again we having the S. So remember these things. So you're having the asbestosis. Most specific is the mesothelioma. Most specific cancer associated with the asbestos. Other findings that we seen in these conditions, the other is what? That is we will be having bicynosis. In bicynosis, remember there will be the cotton. It is associated with the cotton or organ industry or the dust industry. In that peoples we will be seeing the bicynosis. Okay, but having the bags, sugarcane, the sugarcane industry or the sugar that comes in the bag. So पहले बढ़ता बोरी भर के लाना, चीनी की बोरी ले लो, है ना, चीनी की बोरी बचपन में करते थे ना, चीनी की बोरी ले लो उठा के. So that is you need to remember that bagosis. So bagosis you can remember with the bag, and bag what we will put the bag sugar in the bag. So you remember that it is associated with the sugar cane industry. है ना. So you need to remember कि bagosis. Don't be confused with the bicynosis or bagosis. Bagosis जब भी आए तो bag, तो चीनी की बोरी, bag मतलब बोरा, तो बोरा, चीनी की बोरी ले लो. So that वो बोलता है ना चीनी की बोरी. So you remember that sugar cane industry. Or in the bag what we will fill the sugar. You can remember as both ways. Then after that we have the berylliosis. See berylliosis, that is simple. Berylliosis, so beryllium. The element is here is the beryllium, and in the berylliosis there is a non-caseating granuloma that you can also remember. So remember these things. Okay, after that we have the barytosis. So barytosis, remember that is a barium, and we having the barytosis. So barytosis, remember we will be having barytosis, remember the barium. Barytosis due to bariums. Then again remember the one point, we will be having the stenosis. And stenosis, remember if any tin is there or the lead will be there. Lead, what is the called? Pb. What is the symbol of the lead? Pb, that is lead. Stenosis, tin or the lead, and remember we will be having the siderosis. So siderosis, remember it is due to iron. Siderosis will be due to iron. So I hope this is clear, and this is very important. Among them, silicosis and anthracosis should be on your point. Silicosis, silica industry, glass industry, or maybe silica industry, that is the glass industry. Remember the silica or the silly. So silly क्या होगा? Glass. Silly glass. Silly, that is the glass. Then we have the lungs have the nodular fibrosis and the egg cell calcification. There is increased risk of the TB and the cancer. Coal worker pneumonia, remember there will be anthracosis, the black lungs will be there. Asbestosis, that involves the lower limbs. All pneumoconiosis, that involves the upper lobe except the asbestosis. जब सब अच्छे से लिख ही दिया है तो ये भी अच्छे से लिख ही देते हैं. Pneumoconiosis. All pneumoconiosis involves the upper lobe except the asbestosis. The clinical features, we have the pleural plaque, and after that this pleural plaque formation, the pleural nodule will be there. Again, this is important point, the which bodies we seen in case of the asbestosis. So there is asbestos or the ferruginous bodies, asbestos or the ferruginous bodies. The cancer, the most common we see the adenocarcinoma of the lungs, and the most specific we will be having, that is the mesothelioma. The most specific is the mesothelioma. And also the one more point, okay, let's finish this first. Byssinosis, most specific is the mesothelioma, most common adenocarcinoma. Cotton organ industry, bag means thela or the bora, so means bag is the bag, so sugar cane industry will be there. Berylliosis, beryllium, barytosis, barium. Stenosis, tin or the lead. Siderosis, that is iron, due to iron. I hope this is clear and done. See, whatever we are studying, see, for the croak one we studied very little. I know for the croak one the syllabus was very little and was very basic things, but croak 2 we will having some clinical questions, we having the topics that is equally important for FMG. So all the croak 2 topics that is equally important for the FMG exams, I'm talking about the Indian license exams, so just for Indian students. So the croak 2, all the topics will be important for the FMG exams, and believe me, these croak 2 topics that will help you in the future exam as well. So whatever I'm saying, just keep doing these topics very carefully. If you have times, make sure that you are doing it from any other app or more in the details, but this is again the important things and the basic things that will be asked in any further exams, whether it is not just FMG, whether it is your any IMLE exams or any USMLE PLABs, whatever, these are the basic things that will be important for any exam. We are lucky to have the croak 1 and croak 2. Believe me, we are lucky to have croak 1 and croak 2. Because of that we study at least little bit, so that our base will be maintained. So believe me, this will help you in the for future exam as well. So be prepared for everything from now onwards, because you have just 2 months for the croak 2, and after that you will be having further exams, whatever, like in your country or like in India, and further in if you want to prepare for any further exams, then everything is necessary, and this will help you in the clinical practice as well. So make sure that you are revising everything perfectly. Okay, so with this Guru Gyan, let's continue. ठीक है, चलो. Now let's continue with our, come back to our question. बहुत ज़्यादा हो गया ना? Yeah. So we will be having bronchitis we studied, then we having the, we don't have any questions about, just we have the lungs pathology, right? Then bronchiolitis we will study. Bronchiolitis we will study later on, because in the bronchiolitis we need to study again the many more disorders are there, like we having the laryngomalacia and everything, all the pediatrics, all the pediatric group laryngotracheobronchitis and everything we will discuss on one table, है ना? So that will become easy. So all the other pediatrics things we will discuss later on. So here just remember the obstructive lung disorder and the restrictive lung disease. I hope one question is also there that we studied yesterday. So let's do this question 39. A 7-year-old boy with the chronic sinusitis, recurrent pulmonary infections, had chest X-ray demonstrating a right-sided cardiac sellout. What is that means? This is what? Dextrocardia, situs inversus. So they gave the triads. What is that? Chronic sinusitis, recurrent pulmonary infection, recurrent pneumonia, chest X-ray, there is a dextrocardia. So what is the most likely diagnosis? That is Carter-Jenner syndromes. In cystic fibrosis, what we see? The nasal polyp. What we see? Nasal polyp. Okay. Laryngotracheomalacia we will study when we will discuss about the group and everything. Alpha antitrypsin deficiency, this is seen in case of emphysema. This is seen in case of emphysema. Bronchiolitis obliterans, again we will study when we will discuss about the all these pediatrics pneumonias and pediatrics things, little bit about the laryngomalacia, everything we will discuss. Cystic fibrosis, see here they give the mucoviscidosis. So this again we will discuss which gene mutation. There is a CFTR gene mutation will be there. CFTR gene mutations will be there. Okay. There was one more question here about the lungs pathology. Yesterday we told. Okay, I think this question was there only. Okay, so let's continue with the another one. Question number 35. It 9-year. I hope this till now everything is clear. Bandbox resonance 42. 42 atelectasis wala, that we will do. Atelectasis, I need to tell you many things. So let's continue with the 35. A 9-year-old girl has attack of abdominal pain after the fried foods. No fever. She has a pain in the sera point. Sera point. Sera means must. So sera, that is Carr's point. Sera is what? That is the Carr's point. So that you need to remember. The sera is the Carr's point. Liver is the not enlarged. Portion B, duodenal probe 50 ml. What is your diagnosis? So answer here is the biliary tract dyskinesia. For that we need to study about the everything about the biliary disorder. So let's continue with another topic, that is biliary disorders, in which we will discuss about the biliary atresia, we will discuss about the choledocholitis, primary biliary cholangitis, primary sclerosing cholangitis. We will differentiate these features. Okay, so all these things we will discuss. So let's come back. I hope every one of you know all these quadrant and all these. So what we call these things? This is right upper quadrants. This is right, and what we call this is the right. See, we have the 4 quadrant. This is the right upper quadrant. We having the left upper quadrant. This is right lower quadrant, and this is left lower quadrant. This is the segments of the abdomen. Then this is the umbilical area. This is what? Epigastric, and this one is the hypogastric. This is the right lumbar. This is the right iliac. This is the left iliac, left lumbar, and this is left hypochondrium. Left hypochondrium. Left hypochondrial. This is right hypochondrium. Right hypochondrium. Okay, so this is right hypochondrium, epigastric, umbilical area, umbilical segment. This is the hypogastrics. Then we have the left iliacs. This is left lumbar, right iliac fossa. That you need to. These are the abdominal segments that everyone should know. And this is the right. We have the 4 quadrant: right upper quadrant, left upper quadrant, right lower quadrant, and the left lower quadrant. Okay, so let's continue with the other features. That is, we having the. Or should we start with the like very basic things? And in the basic things, you need to start from the like liver's pathology. See, when we talk about the liver pathology, we studied. Okay, let's continue from the starting only, so that it will be easy. See, we will having the liver, and we are having the 2 lobes of the liver, the right lobe of the liver and the left lobe of the liver. Then in the hepatobiliary systems, we have the hepatobiliary system. See, remember, we will having there some type of the cells. We having the some hepatocytes will be there, like the hepatocyte cells will be there, and between the after the hepatocytes we will having the some space is there, and that is known as the space of the DC. Or below the space of the DC we having the sinusoids. Between this again we having the here the hepatocyte cells. So this is known as the this is known as the space of DC. This is what? The space of DC. This is again the space of DC. Okay. Then in between we have the sinusoidal cells, and in the space of DC we see there is some type of the cells that is known as the ito cells. These are the ito cells that help in the storage of the vitamin A. Or then in case of the sinusoids we will be having the Kupffer cells. I hope every one of you know what is the Kupffer cells. These are the, write me in the chat box, the Kupffer cells. What is the Kupffer cells or the Kupffer cells, whatever you can say, the Kupffer cells or the Kupffer cells. Then we'll be having the space of DC. See, the space of DC, this is the space between the space between sinusoids, the space between the sinusoids and hepatocytes code, help in engulfing. Yeah, that these are the engulfing cells, so they are the macrophagic cells. They are the macrophagic cell. They present at the wall of the sinusoids. The space of DC, the space between macrophage, they help in the engulf, so they are the macrophagic cell of the liver. The macrophagic cell of liver. There is the space between the sinusoids and hepatocytes. The space between the hepatocytes and the sinusoid, this is the space of the DC. What they do? They contain the ito cells. What they do? They contains ito cells. So remember the ito cells, they help in the storage of vitamins. This is again the important point. This is help in storage of vitamin. This is help in the storage of the vitamin, and this is also known as stellate cell. This is also known as the stellate cell. This is also known as the stellate cells, and the stellate cells, remember, that is help in the collagen productions. When we will call it stellate cells, when it will help in the collagen production, we call this as the stellate cells. If it is help in the storaging of the vitamin, we call this as the ito cells. Okay, I hope this is clear. Then let's continue with our further. We having that is we having the like the liver. So I hope every one of you know that if you have the liver, in the liver we having the two ducts. That is one, we have the intralobular duct and we have the extralobular duct. Then these duct, the liver duct, they will combine to form a common hepatic ducts. They will combine to form a common hepatic ducts. So this is the right side liver duct, or we can call it hepatic duct, right hepatic duct, and we can say this is the left hepatic duct. So both they will combine to form a common hepatic duct. They will combine to form the common hepatic duct, and when this common hepatic ducts, when they combine with the gallbladder cystic cell. So we have the gallbladder here, and this is what we having the cystic duct. So when this gallbladder combine with the cystic duct, they will form a common bile duct, and this common bile duct they will open into the duodenums. They will open into the duodenum through the major papilla. They will open into the duodenums. So this is the like rough diagrams that you need to remember. Okay, so let's continue with that, with the primary biliary disorders. Again, let's continue with our from the Croc2 point of view. So there is, see, we have the cirrhosis also, but I think cirrhosis there is no question, so we will not going to discuss. And if you want to discuss, you can remember that in the cirrhosis we will be having little bit about the cirrhosis. There will be the nodules formations. There will be the nodules formations that we seen in case of the cirrhosis. Then there is two type of the nodules. We have the micronodular, and we will be having the macronodular. If the nodules are less in size, less than around 3 mm, and if the nodules are big in the size, more than 3 mm, we call this macronodular. If the less in the size, we call this condition as the micronodular. Also remember, in the cirrhosis we will be having the fibrosis also, and this fibrosis, it is made up of collagen. These are made up of collagen. Okay, in case of like the micronodular cirrhosis, if we say let me write it here. we will see also see the fibrosis, and this is made up of collagen. This is made up of collagen. The fibrosis, you can say, that is occurred due to collagen. See, in case of micronodular cirrhosis, you can remember we having the examples like primary biliary cholangitis. The primary biliary cholangitis, we see there is a micellar primary biliary cholangitis. Primary biliary cholangitis, and along with that we will be having some things like alcoholic liver disease. So in both these conditions we see there will be the micronodular cirrhosis, alcoholic liver disease. In both these conditions we see there is a primary biliary cholangitis and alcoholic liver disease. In both these conditions we see there is the patient having the micronodular cirrhosis. If we talk about the macronodular, then remember, like for example we are having the viral hepatitis. We know that hepatitis it is the cause of the cirrhosis. Then in Wilson disease, we know that you have the ceruloplasmin deficiency. So in that condition also we have the macronodular cirrhosis. Along with that we have the alcoholic liver disease. So in alcoholic liver disease, can we see that there is a ALD or ALD, both micronodular as well as macronodular cirrhosis will be seen. So in case of ALD, we having the micronodular and macronodular cirrhosis will be seen. Okay, I hope this is clear. Now let's little more about the alcoholic liver disease, because alcoholic liver disease is examiner favorite. Whatever the alcoholic liver disease, ganja, cocaine, heroin, these all are favorite topic for the all the examiners, not for the Crow 2 examiners but all the examiners. I don't know why. If it is related to like the problem with having the forensic medicines, that about the all these topics, that is very important for the FMG exams as well. So remember the alcoholic liver disease, we will be having the first, the patient will be having the steatosis. Steatosis means will the patient having the fatty liver. This patient will be having the fatty liver. See, the steatosis, that means there is a deposition of the fat in the liver. We call this term as the steatosis. We call this term as the steatosis. So after the steatosis or the fatty liver will be there, so it will lead to the steatohepatitis. There is a fat depositions and that will cause the inflammation of the liver and it will become the steatohepatitis. After the steatohepatitis, there will be the fibrosis, and fibrosis of there, that will lead to the cirrhosis. And when the cirrhosis will be there, there will be the scar formations will be there. There will be the scar formations will be there in these conditions. And also remember the steatohepatitis, you will get a keyword for the steatohepatitis. What is that? In steatohepatitis, you see there is a Mallory, hyaline or the dank bodies. Mallory, hyaline or the dank bodies will be seen. Mallory, hyaline or the dank bodies will be seen. And also remember, we can one more keyword you can get it, that the chicken wire fibrosis. Which fibrosis? Chicken wire fibrosis will be here. And in the cirrhosis, we see there is a nodular plus nodules is there plus fibrosis will be there. Of course, the fibrosis already started in the steatohepatitis. So there will be the nodules will be there as well as fibrosis will be there in case of alcoholic liver disease. I hope this is clear. Steatosis, fatty liver, then it will become the steatohepatitis, then it will become the cirrhosis, and there will be the formation of the scar. Okay. Now let's continue with the primary biliary cholangitis. So this is again the important topic, that is primary biliary cholangitis. See, the primary biliary cholangitis, this is also known as the primary biliary cirrhosis. This is also known as the primary biliary cirrhosis. This is also known as the primary biliary cirrhosis. This condition is the autoimmune. This condition is the autoimmune. This is non-suppurative, means known bacterial inflammations. This is autoimmune conditions. So that is characterized by, there will be the, you can see there is a T cell or B cell mediated. It is autoimmune and it is which mediated? Which cell mediated? That is T cell and the B cell mediated. And in that condition there will be the destruction of the, like the small intralobular and the intrahepatic bile duct. There will be the destruction of small intralobular. There will be the interaction of the small intralobular and intrahepatic bile duct will be seen. Intrahepatic. See, the bile duct can be present inside. The bile ducts can be present inside. What is this started? So there will be the destruction of the small intralobular and there will be the intrahepatic bile duct. See, the bile duct can be the intrahepatic, means inside the livers, and this bile duct can be present extrahepatic as well, that is present outside the liver. So the both, but in case of primary biliary cholangitis, we have the intrahepatic bile ducts are involved, and there is a small intralobular that is present inside the lobules, the duct that present inside the lobules, that will be affected. And remember one more thing about the primary biliary cholangitis, these are associated with the Sjogren syndromes. Sjogren syndromes. And they are also associated with the arthritis. If any patient having the arthritis, this patient is having the possibility of the primary biliary cholangitis, and this patient will be having the gallstone. The is also associated with the gallstone. See, if any deposition in the gallstone, like in the intrahepatic or the intralobular, that also can cause the destruction of the small of the intrahepatic or the intralobular duct. Then remember the antibodies, the antibody that we seen in these conditions. So that is AMA or ANA, that is anti-mitochondrial antibody and anti-nuclear antibody. The anti-mitochondrial antibody, and we will be having the anti-nuclear antibody. I hope this is clear. Then okay, then this, remember these things, we having the antibody. So we will be in the AMA, that is mitochondrials, and we will be having the anti-nuclear antibody. And this also, remember one more thing about the primary biliary cholangitis, that it is associated with more than 50 years old people, and is more common in the females, and if you talk about the ratio, remember 9:1, the 9 times more common in females than the male. I hope this is clear and this is done. Okay. And radiologically, we don't show any sign in case of primary biliary cholangitis. And now let's differentiate these conditions with the there is one more features you can remember for these conditions, like if you are having the patient having the intrahepatic, we are talking about here the intrahepatic. So if there is any intrahepatic deposition of the bile in these conditions, so these patients will be having the, if there is entry like cholestasis will be there, so the cholestasis, that is bile accumulations, the patients will having the fatigueness. And also remember, if there is a hypercholesterolemia will be there, these patients can having the xanthoma, other condition, that is complication that is possible. These patients can having the xanthoma, and these patients can having the xanthilesma. What is the xanthoma? See, if there is a cholesterol these both conditions are the hypercholesterolemia. See, if hypercholesterolemia means more cholesterol level will be there. If on the skin, we call this condition a xanthoma. If it is on the near the eyelid margins, then this condition is known as the xanthilesma. So if this is the cholesterol depositions that on the skin, xanthoma, and xanthilesma, that is the eyelid margins. Then is one more features or one more conditions that can differentiate the primary biliary cholangitis, that is PSC. So PSC, remember, this is the primary sclerosing cholangitis. Primary sclerosing cholangitis. Primary sclerosing cholangitis. See, in primary sclerosing cholangitis, we are getting there is a both are involved, intrahepatic as well as extrahepatic. The both these duct will be affected in primary sclerosing cholangitis. So both these ducts will be affected, and mainly it is seen in case of more than 30-year-old people. More than 30-year-old people, they are, remember, they are the like chronic liver disease conditions. Mainly are the chronic conditions, chronic liver disease conditions. And how it is characterized? There is a progressive course of cholestasis. There is a progressive course of the cholestasis will be there. Progressive cholestasis will be there. Along with that, we can see this patient will be having the inflammation, with the inflammation and fibrosis of the intrahepatic and extrahepatic duct. So remember, in case of the PBC primary biliary cholangitis, we are just having the intrahepatic or the intralobular involvement. Here we having the intrahepatic as well as extrahepatic involvement. There is a inflammation, cholestasis or the fibrosis will be there. And fibrosis is more common. Fibrosis is more common than the inflammation, than primary sclerosing cholangitis. And also remember, the smoking is the protective factor. The smoking is the protective factor. Smoking is the protective factor in case of primary sclerosing cholangitis. After that, you can remember that if it is associated with the PSC, is it associated with the ulcerative colitis? It is associated with the ulcerative colitis. It is associated with the ulcerative colitis. So can I say that in ulcerative colitis also the smoking is the protective factor? The smoking is also protective factor. So the people who smokes, they have very less chance of the ulcerative colitis as well as the PSC. Now you remember that we studied about the C-ANCA, P-ANCA. So in the P-ANCA we studied that we studied about the PSC, we studied about the ulcerative colitis. So remember, they have associations. They are association with the ulcerative colitis, and also what we studied, this is seen with the P-ANCA. P-ANCA. I hope you remember from our where we studied about the P-ANCA in the vasculitis first class. So P-ANCA, it is associated with the P-ANCA. So remember that. And also remember, if we see the radiologically, we see the pruning of the bile duct. That you don't need to remember, but just remember, if in the terms you can just in your memories, in your subconscious mind, put that in mind. If there is a pruning of the bile duct, an onion skin of the bile duct will be seen in case of primary sclerosing cholangitis. But if we talk about the PBC, there is no radiological findings will be seen. I hope this is clear. And remember, the smoking is the protective factor. It is positive, P-ANCA positive. It is P-ANCA positive. The P-ANCA positive. The P-ANCA, where we studied about the Wegener's granulomatosis microscopic with polyangiitis. So in that things we studied that there is a P-ANCA. It is also associated with the ulcerative colitis and PSC. So here we having the PSC. I hope this is done and done. Okay, I hope this is clear. The one more things you can remember about any biliary pathology. See, if we talk about the biliary pathology, so or the biliary disease, the both are the biliary disease, like the PBC or the PSC. So both are the biliary disease. So it is also associated with the alpha 1 antitrypsin deficiency. The alpha 1 antitrypsin. In emphysema we studied that if it is associated, there is emphysema is also associated with the alpha 1 antitrypsin deficiency, and that will lead to the emphysema. Here it is also associated with the antitrypsin deficiency. And if we having the biliary disease, remember biliary disease, so of course there will be the, we know that the lungs will be affected because the alpha 1 antitrypsin deficiency, and in that condition we see the pan-acinar emphysema. We see the pan-acinar emphysema. What is the pan-acinar? See, we see pancytopenia. What was the pancytopenia? Every cell was decreasing. Here the pan-acinar, we studied the acinus, respiratory bronchioles, alveolar duct and the alveoli. So all those ducts are involved. That is a pan-acinar emphysema. All ducts and alveoli are involved. That is a pan-acinar emphysema. And it also affect the liver. In the liver, they cause the cirrhosis. They cause the cirrhosis. I hope this is clear. If you don't know, if you want to remember this point, you can remember with the lal. Mera lal aaya. Mera lal. So L 4 we have the liver, alpha 1 antitrypsin deficiency, alpha 1 antitrypsin deficiency, and L for lungs. So remember, in case of alpha 1 antitrypsin deficiency, the liver is also affected, the lungs is also affected. In case of alpha 1 antitrypsin deficiency and the liver, the pan-acinar emphysema, the liver, there will be the cirrhosis we will be seen. Okay, I hope this is clear. This is done. No one have any doubt. So this is what we have the where is your help? Okay, yes, I got the signal. Okay, so let's continue. So we having the questions. Okay, then after that we having the one more thing here, that is hypotonic and hypertonic things. Okay, then let's come back here and here we will read. Okay, also remember the primary these questions, I don't know if it's there, maybe in the ask in the surgery questions. In the surgery, what is the investigation of the choice? The investigation of the choice, you remember, you can do the MRCP, the MRCP, the MRCP, or we also call it magnetic resonance cholangiopancreatography. What is full form? Magnetic resonance cholangiopancreatography. See, MRCP is what? MRCP, that is, अनुराग सैनी भाई रुक जाओ बताएंगे, ठीक है. तो MRCP, remember we having the MRCP. So the magnetic, this is, you can remember, this is the MRI of biliary tract, the MRI of biliary tract, the MRI of biliary tract. So magnetic resonance cholangiopancreatography. So that is the first investigation of the choice for primary sclerosing cholangitis. So what we will do, we do the dilatations and the stenosis, we both can be seen with the help of MRCP. There is one more technique, ERCP, there is one more technique, that is HIDA scans. So all that we will study one by one whenever will be comes. Okay, till now if anyone have I hope don't know one have any problem, but still if you have any problems, just let me know. Okay, so let's continue with that further. See, this we having the one condition here, that is the hypotonic and hypertonic. Okay, so hypotonic, remember that if you have talking about the hypotonic, so hypotonic, if having the constant pain, if there is a constant pain is there, we call this condition as the hypotonic. But if there is a colicky pain is there, we call this condition as the hypertonic. So remember these two conditions. If whenever we having the cholangitis, if anyone wants to, if anyone will press that area, right upper quadrant pain, so there will the patient will be severe, their patient will be having the severe pain at that side. So that is, there will be the right upper quadrant, any biliary pathology, there is right upper quadrant, dull pain will be there, dull pain will be there. And the dull pain, it can be the constant, it can be the constant pain, or it can be the colicky pain. If it is constant pain, that is known as the hypotonic. If it's the hypotonic conditions, the tone is decrease, or we can call this condition as the hypokinetic type. Then another we have the colicky pain, other we having the colicky pain. If the colicky pain is there, that means we having the hypertonic, that is the hypertonic, or we call this condition as the hyperkinetic type, hypertonic and hyperkinetic types. Okay, so this you need to remember. Then a 9-year-old girl has attack of abdominal pain. So there is a abdominal pain after the fried food. Okay, no fever, she has pain in the Sierra point. See, the Sierra point is also known as the Carr's point. This is also known as the Carr's point. This is just a translation problems. So the Carr's point is the point like present in the right upper quadrant. Okay, you can remember it like that. This is also known as the Carriage point. So if any pain in the carriage point, they will be having the, it can be the constant pain, or it can be the, it can it can be the constant pain, or it can be the colicky pain. Okay, so that you need to understand. Or we having the Carr's point, or also this is the Sierra point. So this is also known as the Carr signs. Carr point, and also we can see there is a Carr signs. So whenever we having the, like the person is eating the dried foods and having the abdominal fluid, so this dried food, this fried food, what they will do, they cause the irritation of any part of the diaphragms, and any, or the maybe there is the fluid will comes and the fat will be there, so the all the fat and any biliary pathology, that will cause the irritation of the right upper pains, and this pain will be referred to the shoulder. This pain will be referred to the shoulders. So that we so called this sign as the Carr sign. So pain will, when the pain will refer to the shoulder, the pain will refer to the shoulder, that sign is known as the Carr sign. So that is what the Sierra point, or the Carr point, or the Carr sign. Okay, so any like problem in the pathology or the right upper quadrant, so there will be the problem, or the pain can be shift to the, pain can refer to the shoulder, and that condition we called is the Carr signs. Okay, the liver is not enlarged, so portion B is 5. What is your diagnosis? So now here the diagnosis, normally telling about the Sierra from the Sierra point of view. So Sierra point, there is a Carr signs, there is pain in the right upper quadrant, pain that refer to the shoulder. This is due to, mainly due to any biliary pathology that can shows. So whenever the Carr sign will be there, so that can be the possibles that the pain is problem having the, in the problem in the hypochondral regions, and that will lead to the biliary tract dyskinesia or the hypotonic sites. Is it can be the hepatocirrhosis, chronic duodenum, peptic ulcers, acute colitis. See, in case of the chronic duodenum, they will give you something history of peptic ulcer, like they will give you some history of Helicobacter pylori. Colitis is what? That is the pain, like inflammations of the, like if any stone is there, colic pain, or the colitis, or the stone will be there. Then chronic duodenum, there is nothing about the chronic duodenum, or nothing they mentioned also. Hepatocirrhosis, cirrhosis, see the cirrhosis, when will be the cirrhosis? Whenever we will get the nodules formation. But here we can see there is no nodules formations, the liver is not enlarged, liver is normal, there is no cirrhosis, no fibrosis, no nodule formations. That why we have don't having the hepatocirrhosis. So this is again the simple things we having the note need to do, that is the problem in the biliary tracts. So it can be the problem in the biliary tract due to which the pain has been arise, and this pain can subside by itself also, because they didn't give many much more history, and this pains can be subsides easily also. And the hypotonic, they didn't differentiate it here, but if you want to differentiate it, the hypotonic there will be the constant pain, and in hypertonic there will be the colicky pains. Okay, so that you need to remember, hypertonic, colicky pain, and constant pain if in the given in the question, that is hypotonic. If they will give in the question colicky pain, hypertonic, but they did not differentiate it here. If questions come, then you can differentiate it like that. Okay, I hope this is clear. Yeah, okay, so no one have any questions, so let's continue. See, one more condition is there, like the biliary atresia. The one more conditions here, that is the biliary atresia. In biliary atresia, what will be there? There is absence of biliary channels. If those channel that I told you, the common bile duct or all these things, the absence of biliary channel. So if there is these channels will be absent, like common bile duct, common hepatic duct, left hepatic duct, intrahepatic, extrahepatic. So these all we can consider it as the biliary atresia. So biliary atresia, the absence of biliary, the absence of the biliary channels. What happened? Okay, now there is absence of what? Biliary channels. The absence of biliary channels will be there. and it is due to inflammation, or we can say the inflammatory fibrosis of biliary tracts, the inflammatory fibrosis of the biliary channel or biliary tract. See, if any obstruction is there or any biliary channels will be there, this we will not able to get the bile in our duodenums, and that conditions will lead to the jaundice. There will be the steatorrhea, the fat will be in the stools, and the patients can having the hepatomegaly due to accumulation of the bile. The investigation of the choice here in this condition is the HIDA scans. The investigation of the choice in this condition is the HIDA scans. So just remember, there is a CT scan type of the things, that is the HIDA scans, that you need to just remember. Biliary atresia, there is absence of the biliary. Normally they don't ask you the investigation of the choice. So just remember biliary atresia. See, the absence, they have the common bile duct, we have the common hepatic duct, we have the intrahepatic duct, we have the extrahepatic duct. So based on that, which channel is affected or which channel is absent, we consider that as the biliary atresia type 1, type 2, type 3, type 4. And along with that, we have the treatment as well, like a Roux and Weiss surgery, and we have the Kasai surgery for the biliary atresia, so that we can cut everything and chop everything, and with the we will take the jejunums and we'll combine the jejunum with the biliary atresia, but that no one will ask you, so I'm not telling you everyone, not telling anything about that. So just remember the biliary atresia. What is that meaning is that absence of the biliary channels, and it due to inflammatory fibrosis of the biliary tract. Okay, for your subconscious mind, I just tell you that in biliary atresia we have the types, type 1, type 2, type 3, type 4, and based on that we will having the, like, if there is a absence of the common bile duct, then type 1, then if you have the hepatic duct, the type 2, if there is extrahepatic duct is involved, that is type 3, if there is intrahepatic plus extrahepatic, everything is called the type 4. And based on that we do the surgery. For second, third and fourth we do the Kasai operations, and for the type 1 we do the Roux and Weiss surgery that we do. And okay, so that you need to understand. I think that is more than enough. Okay, so let's continue class until today. Class will be till I don't know. Are you tired? Little easy questions, don't worry, है ना? See, just few more minutes and we will be having. Don't be tired. You are the future doctors, है ना? Just we have that two little questions, silly questions that you know by just एक चुटकी में कर दोगे तो बस कर लो, आ जाओ. A baby was born at 36 weeks of gestation. Delivery was normal by natural way. The baby has a large cephalohematoma. The result of the blood count are hemoglobin 120, erythrocyte is itna. Total serum bilirubin is 123. Out of that, direct bilirubin is less, indirect is more. So this is the example of the indirect jaundice. This is example of the indirect jaundice. So what are the causes of hyperbilirubinemia in this case? See, whenever having the hyperbilirubinemia, see, whenever we having the RBC, the blood, and RBC, in the RBC we have the heme particles. When it will having, it is a break, it break into the bilirubins. It will break into the bilirubins. So RBC break into the hemes, and the heme we have the biliverdin reductase. First they will broke into the biliverdin, and this biliverdin further will break into the bilirubin, and this bilirubin is the main cause. And what is the main etiology here? That is due to breakdown of the RBC. So what is the cause of hyperbilirubinemia in this case? That is in any case, that is the erythrocyte hemolysis. Whatever the case of jaundice, the first cause, the first etiology of that disease is the erythrocyte hemolysis or the RBC hemolysis, and that hemolysis will lead to the heme formation, biliverdin formation, bilirubin formation. But this bilirubin, the form that is here, that is the indirect bilirubin, and this indirect bilirubin, or we can call this condition as the unconjugated bilirubin. So this unconjugated bilirubin we need to conjugate with the help of UDP glucuronide transferase, and this will convert into the conjugated bilirubin, and this if accumulation of the indirect, we call this condition as the prehepatic jaundice. Everything this is all the Croke 1 point of the view, and so just remember this is what indirect erythrocyte hemolysis. I will send you the one clip of the Croke 1 rapid revision so that you will be able to understand. I will try to share. I don't know where I taught in which. If anyone remember, just let me know that which video was that. Okay, so that we will able to make the clip of that, and I will share that clip only. Okay, don't leave, है ना? If you are tired, don't leave. I know you are tired. You are not tired. That fatigue is more important than your goal. A 4-month-old girl with a blonde hair, then blue eyes. Oh, no dinner. हाँ बस थोड़ी देर रुक जाओ. Just few more minutes and we will finish. ठीक है? A 4-month-old girl with a blonde hair. I know you love the blonde hair and the blue eyes. Blue eyes hypnotize. Mouse AD order of the sweat and the urine, delayed phycomotor development. The most typical laboratory data for this disorder is the mousy odor. This again we studied everything. This is the Croke, again the Croke questions. See, just telling you I think this will be the last question for today. हाँ ठीक है, this can be the last question. So just be focused. देखो phenylketonuria. Phenylketonuria, what we studied in case of the phenylketonuria, remember this is the most common, what was studied, most common amino acid. Oh, let me write it here only. Question phenylketonuria. The phenylketonuria. The phenylketonuria is what? This is the most common amino acid metabolisms. The most common amino acid metabolisms. So remember, in case of phenylketonuria, what will be having? We will be having musty mousy odor. We having the musty mousy odor of the urines. And why this musty mousy odor of the urines? This is due to phenyl acetate. This is due to phenyl acetate. Due to phenyl acetate excretion. Due to phenyl acetate in urines. Excretion, you can understand it a little bit. Due to phenyl acetate in urine, you can remember it like that. Due to phenyl acetate in urines, musty mousy odor of the urine. Why it is due to phenyl acetate in urines? See, normally we having the phenylalanine. So this is what we having the amino acid, and when this phenylalanine, we having the enzyme, the phenylalanine hydroxylase. We have enzyme that is phenylalanine hydroxylase. We have the phenylalanine hydroxylase. So this phenylalanine hydroxylase convert the phenylalanine into the tyrosines. It convert into the tyrosines. This tyrosine further convert into the melanin. This tyrosine further convert into the melanin with the help of tyrosinase. So in case of phenylketonuria, this enzyme will be deficient. In phenylketonuria, what will be happen? In phenyl PKU is phenylketonuria. So this enzyme will be deficient. Enzyme will be deficiency. This phenylalanine hydroxylase will be deficiency. So if this enzyme will be deficiency, there will be a decrease in the tyrosine. There will be a decrease in the tyrosine. If the decrease in the tyrosine, there will be the decrease in the melanin. So you will get the blonde girl. Okay, the decreased melanin. So what will be there? Hypopigmentations. Hypopigmentations. So hypopigmentations, what you will do? You will see the fair skins. You will see the fair skins girl, blonde hairs. Blonde hair due to melanin decrease in the hypopigmentations. Blonde hair. You will see the blue eyes, hypnotize, kar gayi teri. So that is blue eyes. Okay, blue eyes you will be there. So then phenylketonuria, remember we will be having the brain damage. You will be having the brain damage. So brain damage, we can say there is a mental retardations will be there. In mental, there is a one more condition, that is alkaptonuria. In that condition, we don't see the mental retardation. Here we see the mental retardation, and also we see there is a microcephaly. The microcephaly. Along with that, in phenylketonuria, we see the seizures as well. We see the seizure as well. Okay, if there is a decrease in the tyrosines, can we say that there is an increase in phenylalanine? There is an increase in the phenylalanine. If there is an increase in the phenylalanine, can we say that this increase in phenylalanine, what they will do, they increase the phenyl acetate. They increase the phenyl acetate or the phenyl pyruvate, increase the phenyl pyruvic acid, because this phenylalanine will convert into the metabolite of the phenylalanine, phenyl pyruvate. Okay, so I hope this is clear. This increase in the phenylalanine, they will increase the phenyl acetate, they increase the phenyl pyruvate. I hope this is done and done. Okay, this phenyl acetate will accumulate in the urine and it will cause the musty odors. So this you need to remember. If there is a musty odor, musty or the mousy odor. And for the diagnosis, remember, we do the FeCl3 test. FeCl3 test, ferric chloride test. Okay, so in the ferric chloride test, again we will see the musty odor urines. The test for the musty odor urine is the FeCl3. I hope this is done. And the next questions we will do the positive urine ferric chloride test. So what the most typical laboratory data, we have the positive urine ferric chloride test and give the musty or the mousy odor. Then we have the neonate 5 days old. So what vaccination dose of the BCG vaccine in mg? So remember this dose 0.05 mg. And also remember, for the BCG we have one strain that we used, that is Danish 1331. The strain for the Danish BCG vaccine we use, that is 1331. I hope everyone knows about the full form of the BCG, that is Bacillus calmette urine. Bacillus is the name of the bacteria, calmette urine is the name of the scientist. I hope this is done. Okay, so remember this value or the dose of the vaccination that is necessary for this child, that is 0.05 kg. And where we give it intradermally. The vaccine, how the vaccine is given? If this vaccine is given intradermal route. Okay, intradermal route. Okay, so I think telangiectasis. Okay, so most of the I have just one questions left for today that I thought I will cover till 40, but no problem, we will cover it tomorrow.